Glad you're here. Glad you could come. I have been instructed that I need to get up high on the stage so the people on the camera can actually see me in the lights. But this kind of makes you a little bit fuzzy, with all the light. But we'll get along with that. I'm still down there with you at heart, okay? So let's start with a word of prayer. Father in heaven, we're thankful that you have given us hearts that pump physiology that is resilient, and that you want for us full and happy and healthy lives. As we think about heart disease and learn about how our bodies work, we ask that your Spirit will be with us to guide us, that we may understand to act on your instructions and what you would teach us is best. Thank you for your blessing and your Spirit this afternoon, in Jesus' name. Amen. The heart of the matter, where are we? So we'll talk a little bit about heart disease. I appreciate Scott taking me on a little walk down to the Billy Graham Education Center, and that was very nice, and the leaves out are beautiful. And we were able to exercise our hearts a little bit, going up and down hills. You have nice ones here in Florida. They're not quite so, we have the Florida Alps. They call it Mount Dora. Okay, let me have the clicker, thank you. Make sure that we're on here and get ourselves going in the right direction. Okay, a lot of people are kind of confused about cholesterol. What is it? We think of it as a fat. Is it really a fat? This was supposed to be 3 different kind of pictures of cholesterol. The first one on top there is the one that you can see, is the one where you draw with the pencil, when you're trying to take notes. The one behind it is, and the ones behind it are 3-dimensional. The stick figures and then what it actually looks like physically. It's not really a fat, although it is soluble in fat, and one end of it is soluble in water. I like to think of cholesterol as detergent. If you get grease on your pants, you take the pants off, you put them in the washing machine, and you turn on water. The only reason you expect the grease to come out of the pants is because you add a detergent, because oil and water don't mix. Our bodies are water systems. We're 65, maybe 60, 65, maybe even 70% water. But fat is absolutely necessary for our lives, our cells, our body to function. Didn't we talk a little bit about this recently? No, it was another presentation. Did I mention anything? We talked a little bit about it last night. Okay. So we need, fat is the cell walls. The little organelles inside are all separated by fatty layers. Fat is used as an electrical insulation on nerves, which is kind of interesting, and hormones and other messengers. So fat has many uses, and we need that. We need that fat badly in order to be able to live. But how do we get fat into a water system? Well, fat, to mix with water, needs a detergent, and cholesterol is one of the main detergents that allow those two to work together. And I suppose it would make sense that when you take a lot of extra fat in, your body needs to make more detergent. By the way, do you all know where the soap dispenser is in the body? They call it a gallbladder, right? So, and it's a little soap dispenser there. When you eat, the body senses the fat, little hormone called cholecystokinin goes to the gallbladder, makes it contract, and the soap goes into the intestines to help that process. So that's what cholesterol is all about. Now, you've probably heard about fats, and you've probably heard the words saturated fats, polyunsaturated fats, monounsaturated fats. Let me share a little bit of chemistry with you. It's at this point that my wife's eyes glaze over. She thinks this is too much for all of you, but I will go ahead and share it with you in as simple way as I can. Carbons each have 4 hands. And when they line up in a chain, we call them a fat. Each of the extra 2 arms is filled with hydrogen. It's a very small atom compared to the carbon. And when they're all full, we say, all the hands, it's saturated. There's no more room for any more. So it's a saturated fat. And as it's laid out here, it is long and straight. Now, if you'll excuse the anthropomorphizing, if a couple of carbons fall in love, they hug, right? And when they do that, they have to let go of a hydrogen. So we call that a monounsaturated fat. So there's one pair of carbons that have let go of their hydrogens. These, interestingly, are kind of bent. Now, I like to describe these fats like firewood. You know, when winter's coming and you got to put in your firewood, you cut it all up and you stack it up. If those are all nice, straight pieces, you can make a stack of firewood 5 or 6 feet tall, and it can work as a windbreak. But you start getting crooked pieces in there, and the thing gets really unstable, right? So saturated fats are straight, and monounsaturated fats are bent. Okay? Now, you don't have to be a biochemist to recognize this. You can see this right on the dinner table, okay? When you break out a stick of butter and you put it on a plate in the middle of the table, you can actually put a knife into it and spread it. That's those long, straight pieces of firewood. If it's monounsaturated fat, if they're bent, what do we call it? It's olive oil, right? So it's a monounsaturated, and at room temperature, if you put that on the plate, it's going to flow everywhere. So you see, you don't have to be a chemist to recognize a saturated fat or an unsaturated fat. Saturated fats are very helpful for baking pies and cookies and those types of things. They have specific physical characteristics that make them work. You don't try to make a pie crust with olive oil. It just doesn't work. So the long straight one, and this is kind of more what it looks like. It's not exactly a straight line. They're jagging just a little bit because the carbon has 4 different directions and they're not all in one plane. So you have stearic acid, which is the long straight one saturated, and then you have oleic acid, which it has that one bend on it. So you can kind of see that physical structure there. Now, polyunsaturates are interesting, and that includes ones with 2, 3, 4, 5, 6 different pairs of carbons that have fallen in love. And they just have more bends, right? So you've got the monounsaturated bend, and another bend, and another bend, and another bend. I mean, you can have lots of bends on these things. Interestingly, this end always stays straight, okay? So the bends are always on one end. Those are polyunsaturated fats. And they're bent, they're much more flexible, and they're much more unstable. That is, they can be damaged easily. You probably have run into damaged polyunsaturated fats when you open up the refrigerator, get some oil, and it's rancid. In essence, that's a damaged polyunsaturated fat, okay? So for what that's worth. So what does it mean? We've kind of covered the fats. You've got lipids, is fat, grease, oil. Triglycerides, the body moves fat around in the bloodstream with, they call triglycerides. That you've got 3 fat molecules held together with one glycerol molecule. So that's kind of the way it works. Triglycerides is another name for fat in the blood. You have the saturated, the unsaturated fats, and then of the unsaturated, we have monos and polys. So this particular picture with the red line kind of at the bottom is supposed to let you know you're starting that polyunsaturated. Now, does the red line look better or do I look better? I mean, okay, the animation may be better here. So if we think about these, we've got saturated fats are bad. Monounsaturates are good. Polyunsaturates are good to a point, but they have a bad side with that rancidity. Trans fats, and I've got to introduce you to those, are bad, And the partially hydrogenated are also bad. So let me say a little bit about that. Read your labels. Sorry, we're missing some of the action in the slide, but I think you'll get it. So the story goes like this. From the Framingham study, we learned that high cholesterol puts us at high risk for a heart attack. Have you heard this before? I mean, this was 1950s, right? So we should be aware of this. And so we said, let's see, cholesterol is made by animals and not by plants. We should be able to get the cholesterol out of our diet, and that should help decrease the cholesterol in our blood. And so they did some studies to try to find out if removing cholesterol from the diet would actually decrease the blood cholesterol and hopefully decrease our heart attack risk. Well, it only dropped by like 10%. It really wasn't all that much. And they said, well, what happened? Well, it's obvious to me now. Can anybody tell me what was wrong with that line of reasoning? We're animals. We make our own cholesterol, right? And especially when we get those long, straight fats. They're hard to take apart, they're hard to move around, and we need extra. This is the way I kind of explain it. It's not exactly right biochemically, but, if you take the argument, it's reasonable. So when they're long and straight, they stimulate more cholesterol production so we can move around stuff that doesn't come apart very easily. So we figured that out, and we said, okay, saturated fat is bad. We need polyunsaturated fats. So the public, as they hear about it, start demanding unsaturated fats. Well, it's not as easy as just putting in unsaturated fats because, as we pointed out, you just can't make a pie crust with polyunsaturated fats or even monounsaturated. Oils act differently. So we still wanted, our pastry goods and all these things the way we're used to them, but now we're requiring polyunsaturates. So what is industry to do? Well, they reached back into history, and this is back around early 1900s, somewhere in there. Someone had figured out how to do something called hydrogenation or partial hydrogenation. So what they do is they take the unsaturated fats from the plants, they put them in a big vat, they put in a little bit of nickel. I think one of the things they use is Rainey's nickel. They run the temperature and the pressure up, and they do through time to actually change these fats. So instead of being bent as oil, they turn straight. Butter was expensive. It takes cows. You can actually get from corn oil, you could put it in partially hydrogenated, turn the bent fats straight, and then you'd have something, what do they call it? Margarine. Have you heard of that? Okay, so margarine. And early on, there was this big fight back from the farmers that says, you can't do that. That's cheating. It's our industry is important. So they made this law that they couldn't make it yellow. Had to be white. So in the old days, you'd get this tub of margarine, and there would be a little capsule of beta-carotene in there, vitamin A, which is yellow, and you mix it up, and then it looked just like butter, right? Okay, so that's the way they used to do it, and that's how industry kind of fights it. What happens is when they could call it polyunsaturated, but it was straight, and they did that by doing this with it. So instead of being, they call this boat shape, right? It has more a straight shape, chair shape, they said, with a little bit of a jog in it. And that jog, this is called trans fat. So that's what they call it, cis versus the trans fat. And those trans fats, now on the labels, it said unsaturated fat, but when they baked with it, it acted like saturated fat. So they said, good answer. And the scientists started to ask the question, is this really a good idea? And when they found out, for example, in the Nurses' Health study, a reasonable kind of average serving of like 6 to 8 grams of trans fat a day increased your heart attack risk by 51%. Of course, that was nurses. It's probably not that, well, I think it's everybody. Okay. So then the word came out, look, trans fats are not good. And it was probably 16, 17 years ago, the American Heart Association got together with the industry. They said, let's have a meeting. What's taking you so long to get the trans fats out of our diet? So they've been working at it, and we find things decreasing. There are some things that it's still not out of. Earlier on, and I don't know what the numbers are now, but earlier on, the trans fats, 50% of the trans fats in Americans' diet was coming from beef because the bacteria in a cow's stomach will change fats into trans fats. So that's a concern. Now, it may be different now. The beef may actually be higher because they're removing the kind of manufactured trans fats out. So it's an interesting challenge. Partially hydrogenation is how they make trans fats, so that one also has a very kind of frown next to it. Does it make sense to you? Any questions about fats? I hope to have demystified them a little bit for you. It's straight, or it's bent, or it's bent wrong, or it's bent multiple times, okay? And so if you can put that all together, you'll understand more than most. And if you can recognize it on the table, that's even better, okay? So there's a picture of the unnatural position in the trans fats that acts like our body, just like the saturated fat. And so that's kind of the way it happens. Now, this is an interesting slide for people to understand. When you think coconut oil, you think saturated fat, right? So you can see on the slide, these are considered saturated fats, but coconut oil, while it has a lot of saturated fat, it still has some monounsaturated and some omega-6. Butter has saturated fat, this is the omega-6, and then, no, there's the omega-6. This is the mono, and that's the omega-3. So we talk of them as if they're saturated, but it's not pure saturated. Does that make sense? It has other things in it. And the same with those that are here in the monounsaturated. So there's olive oil. It has some saturated fat in it. And then this is, of course, the monounsaturated, and it has a little omega-6 and omega-3. Have you ever seen on a label fractionated olive oil? Because sometimes the health foods will say this has fractionated olive oil, expecting that the ignorant public will think that's olive oil and healthy for them. You've probably put olive oil in the refrigerator in the past, right? And you put it in there, and as it gets cold, you find something turning hard in the middle. That's the saturated fat. That's how you fractionate olive oil to get saturated fat so you can make pie crust with it, okay? So that's kind of a trick that the chemists will use to make that happen. So canola oil, also considered monounsaturated, has quite a bit more omega-6 and omega-3, and peanut oil, you see, is fairly high in omega-6. Here's the polyunsaturates, so safflower, lots of omega-6, but it still has some saturated fat. And you can see kind of on the way down here, both the omega-6 and the omega-3. Now, I suppose I should take this opportunity to share what omega-3 and omega-6 means, okay? Remember I told you there's the polyunsaturated fats, right? So omega-3 is the first bend, is 3 carbons away from this end. And omega-6, it's 6 carbons away from the bent end, okay? So that's the difference between them. They're both polyunsaturated fats. Both of them are essential fats. We can't make them. We have to take them in. And there's a lot of interesting details about those. Does anybody have any questions about these?
I consume a lot of this. It's called Smart Balance. And it says supports healthy cholesterol levels. And on the label, it says 320 milligrams of omega-3, but below that it says ALA per serving. So I'm wondering is where this falls and how healthy it could be.
Excellent question. So now that we've learned that trans fats are bad, and we want the polyunsaturated fats, industry has come up with a way to solve that. So, I can't believe it's not butter, right? So what they found to do is to take the polyunsaturated fats, which would be at room temperature oil, and they've suspended it in a carbohydrate gel. So you can actually, take it with your knife and spread it. But if you look at it, if you melt it and then try to see if it'll turn solid again, it won't. So this is actually a very good way it's one of the better spreads, right? So you're going to get more of the alpha-linolenic acid, ALA. That's the omega-3.
Oh.
Okay? And so that should be good for you. It should be, stable, and it shouldn't be exposed to air, which tends to make them unstable. And you shouldn't have any of those trans fats in there. Okay?
Thank you.
So thank you for asking that question. So we can clarify. You got another question here? Yes.
Where does flaxseed come into this mix?
Flaxseed is one of the highest in omega-3. It's not on our list here, but it's going to have a lot more omega-3, not that it doesn't have some other things. So, and again, that's how far that first bend is. Our American diet tends to get way too much omega-6. The ideal ratio is about 6 omega-6 for 1 omega-3. And the Americans are running closer to 16 or 18 of the omega-6 to the omega-3. And the omega-6 tends to make more inflammation in our body. We would like to have less of that and more of the omega-3. So that's part of the processing that goes on when they tend to use oils that are kind of high in the omega-6. So safflower oil, sunflower oil, corn, soybean, cottonseed. If we had the flaxseed up here, it would be showing a lot more of the omega-3. Walnuts are another one that are very high in omega-3. Okay, we got 3 more hands, so Mo needed Mo steps.
I have heard both that coconut oil is good and that it's bad.
So she wants to know about coconut oil being good or bad. You're asking very interesting questions here. It's hard to completely categorize, right? When you take it out of its natural state, when we get it as the way God made it, it doesn't seem to be a problem. You go out to the islands and, before the white man came and brought their Spam, right, and other junk food, they didn't really have the heart issue, right? They were eating the coconut, but they were eating the whole coconut. So it would be a better way of doing it. Now, as God makes plants, there's all kinds of things that we're simply learning about. I heard a lecture several years ago from a lady researcher in San Francisco who had discovered lauric acid. Now, lauric acid is a 12 carbon. Okay, the stearic was the 18. 12 is lauric acid. And when they gave the equivalent of about 6 coconut macaroons to people with HIV, it dropped their viral load by 50%. The lauric acid was interfering with viral replication, was confusing things. Now, we say coconut oil is bad. I would say more palm oil is bad because it's really high in palmitic acid. That's the 16 carbon one. That one really stimulates more cholesterol than anything else. We have a very efficient enzyme that takes the 18 and puts a bend in it quickly. So actually, it's the palm oil that's going to be the very worst for our cholesterol. I hope that helps. Coconut milk is the stuff when you take the meat and you squeeze it and the white stuff that comes out. That's going to be relatively unprocessed, although you're missing some of the fiber. So I think that's not unreasonable. The coconut water, of course, it's got electrolytes and a little bit of glucose in it, but that doesn't have hardly any fat in it at all. I taught school in the Marshall Islands for a year when I was in college. And they had like 5 or 6 names for coconuts, depending on where they were on the cycle, So we think of just one. Well, they're all a little bit different. So eat the whole plant. There was another hand over here.
I was wondering about avocado oil. Because
Well,
there's so many different oils. I've even seen algae oil.
Yeah. So when it's separated from the plant, it brings with that some negative effects. And I say, it's better to eat the whole avocado than to eat the avocado oil. It tends to have quite a bit, as I remember correctly, of polyunsaturated oils. If you take, for example, flax oil, it's very unstable. Light, time, and air will destroy it. If you get it, it should be in a dark bottle. You should keep it in the refrigerator or the freezer. The safest way to do it is to grind your flax seed just before you eat it, and then that will release the omega-3 oils for you. That was probably more than you wanted to know, but some of you have been asking the question, so I hope that's helpful. Okay, let's move on a little bit. I think we've done a good job with that. Is there one we missed? Okay.
For those of us who are not as advanced, and I'll catch this fellow later to make sure I know about his, but what is the best one up there to use just generally for neophytes, people who don't have a clue?
She wants a simple answer, doesn't she?
I don't think that's happening.
It's better to get it in the whole plant whenever possible. The monounsaturated fats are probably your safest ones. So, I know, back it up so you can see them. So, olive oil, canola oil tends to do fairly well, and peanut oil. So, they have less of the polyunsaturates, which tend to be unstable. If you're deep frying, then it's probably better to use a saturated fat and try to keep the volume way down, right? So you're not taking very much, because they're the most stable when they're, as I shared this morning or earlier, the temperature has to get up like over 400, 500 degrees before you start to break those things. The worst thing happens when you drop them off the meat onto the grill and they crack. So that's the most dangerous fat. Stay away from those. That's more a cooking style, okay? Okay, now when we talk about cholesterol, the doctor does your lab test and you get this stuff that's LDL and HDL, and there's others as well. Fat is managed in the body in a little different way than the carbohydrates and proteins. The long fats, when they go into your blood, they go out in bundles. We call them chylomicrons. If those bundles were to go to the liver after you eat a big fatty meal, cheeseburger, fries, and a milkshake, right? That would float into your liver, and it would completely plug up the blood vessels, and it would kill you. So God has designed our bodies so it doesn't go through the blood. It goes into what's called the lymphatics. So these are the vessels that are taking waste from the body up, and they dump it in just in the inferior vena cava, just below the heart. And then it mixes with the most amount of blood as possible. Apparently the body adjusts. There is reported by missionary physicians in New Guinea, where they eat plant-based everything. When they have their big holiday and somebody roasts the pig, and they eat a whole bunch of that pig, they get a liver failure that cannot be stopped by anything medicine can do, and that's all that fat kind of hitting the liver. So I'm glad that God has built this grace into our system. It would be dangerous, it is dangerous, to go from a very low-fat diet to a high-fat diet all at once. Not a good idea. So it comes in, it goes into the lymphatics, is dumped in there behind the heart. Now, I have on the screen a picture of a chylomicron. I wish I could find the electron micrograph that I saw when I was in medical school. Been unable to obtain it. It was absolutely amazing. There's this LDL particle, which is actually smaller than the chylomicron, in the electron micrograph, and right next to it is a red blood cell. And the size differentiation is incredible. So the fat globule is released into the bloodstream, and it floats along until it gets stuck in a small blood vessel. And then there's an enzyme on there called lipoprotein lipase, which releases the fat into the tissues that are around. That makes it smaller, so it scooches a little further, and the enzyme again works, and those just get smaller and smaller and smaller as the fat is deposited throughout the body. That's discouraging. Ladies, you might as well not eat the candy bar. Just apply it directly to your hips. That picture has been very helpful to me when I think about eating free fat, because I know that's what happens. Fat preferably goes into storage. Your body chews on carbohydrates for a while, and then we'll start looking for the fat when the carbohydrates are gone. That's, in my mind, one of the big problems with things like Atkins diet and the low carb, because that's not the way the body was designed to work, right? So those fats can plug things up. Chylomicrons are the first ones. Now we're going to talk about the LDLs and the HDLs. LDLs are the bad cholesterol packages. The higher your LDLs, the more likely you are to have a heart attack. Now, to help us remember which is which, I have changed the name, okay? They're called little devil lipoproteins. That's what the LDL stands for. And they take the cholesterol out, and they deposit it, and they increase your risk of heart attack. A little more about that later. HDL stands for heavenly darling lipoproteins. The higher your heavenly darlings, the less likely you are to have a heart attack. Does that make sense to you? Okay, so that's helpful, and hence the little angel, hence the garbage picker-upper. So in the picture. So those are the cholesterol packets. We'd like our LDL to be low. We would like our HDL to be high. Unfortunately, these are not 100% accurate, right? We learned about these in the Framingham study. I heard William Costelli, the fellow who ran that Framingham study for a number of years, lecture on this. And he pointed out that 1/3 of the people who have a heart attack this year will have a total cholesterol less than 200. That is, having a cholesterol that's low doesn't prevent you from having a heart attack. And interestingly, the LDLs, it's about 1/3, if I'm remembering correctly. I think it's 1/2. One is 1/3, one is 1/2. Half of the heart attacks half of the heart attacks will happen in people whose LDL is less than 100, which is kind of the goal. So these are good for populations, but they're lousy for individuals. There are people who have high cholesterol who will never have a heart attack. There are people with low cholesterol who will have heart attacks. Remember Tim Ressert? Do you remember that, the sports guy? Yeah. He went to his cardiologist. He had his treadmill test. He did just fine. His cholesterol was perfect on his cholesterol-lowering medication. And a month later, he drops dead of a heart attack walking down the hall at the office. So the numbers are not protective. It's something that I wish we could understand. Some people with high cholesterol, if they have a good lifestyle, are much less likely to have a heart attack. I mean, there's a lot of factors. We don't have a good way of predicting for sure. But the lifestyle is going to be the most important thing, more important than the numbers. I tell my patients the numbers are for motivation. Where you are when we start, let's make lifestyle changes and see if we can improve them. Just because they don't get where you want them to be doesn't mean you're not gaining the benefit. So the lifestyle is really the most important piece. So how does LDL work? The LDL particles that are damaged by oxidizing of the cholesterol, oxidizing of a lipid or a protein, are not recyclable. The liver won't pick it up, take it back, and recycle it, so they have to be deposited somewhere. These are the small, dense LDLs, and they're deposited in the blood vessels, and you can kind of see them here. LDL particles coming in, it's oxidized or damaged in some way. The monocytes come in and turn them, kind of grab them up, turn into macrophages, and then these foam cells, they're called foam cells because they're full of fat, and when the pathologist prepares them, they wash all the fat out of the way and they look like foam. That's what it looks like under the microscope. So that's the kind of the pathophysiology. That's what happens with these LDL particles. The large, fluffy LDL particles are not nearly so much a problem. You can have those checked in blood tests. It's not the regular kind of lipid panel, but it looks at all the different particle numbers and size. So we looked at saturated fat. We said that's bad. We looked at We got the trans fats, and then we threw those out. Now we recognize polyunsaturates are better. We keep discovering things that are wrong, right? So we looked at hearts that had heart attacks. We looked at blood vessels, and we see the cholesterol deposits. We knew that those cholesterol deposits, and this is the way the artists seem to always portray them. There's a cholesterol deposit in the wall of the artery. That's where the heart attack happens. It's plugged up. It's the way that it's always shown. I remember when the study came out, my mouth fell open. I could hardly believe it. You see, over the years, hundreds and thousands of these angiograms were done on a daily basis, right? I mean, they add up over time. And occasionally, somebody would have a heart attack while they were on the table getting the test done. So the question is, where does the heart attack happen? Now, there's no safer place to have a heart attack than with the cardiologist right there, right? You just drop a little bit of clot buster in and it's taken care of. So that's a good place to do it if that's your plan. What they discovered was that the majority of heart attacks were not happening where the blockage is. They're actually happening downstream. One of my friends likes to call that pimples on the arteries, right? And they're the juvenile plaques, the little ones, and they're unstable. The thick ones tend to have a fibrous cap. They're the ones that cause angina or chest pain when you're actually exercising and then go away when you rest. Whereas when there's a clot happening a little further down, it's either a full heart attack or unstable angina. So, that's a real surprise to us. Now, the way that doctors decided to work with this blockage when they saw it initially was to say, there's two kinds of doctors, for those of you that don't know, okay? There's two kinds of doctors. There's the ones that operate and the ones that use pills, okay? You understand? And there's a hierarchy. And the surgeons are always on top, it seems. Now, this is my observation. I have no statistics on this, okay? Agreed? Okay. So, blockage. And a surgeon comes riding in on a white horse and says, I am going to solve this problem. So after some experimenting and getting things taken care of, we get something called the bypass, right? So we crack the chest open, we kind of spread it apart, we grab a vein from the leg, and we attach it from the internal mammary artery just beyond the blockage, and we solve the problem. That's expensive. It's pretty dramatic, too, when you get your chest cracked open. And there's some recovery for that. It's not a benign sort of a thing. There's danger from it. So it was the internist's time, right? So they come in, and the cardiologists, of course, have a great plan. What they're going to do is to put a balloon in there right where that blockage is and open it up. Then the blood can flow through, right? So that works really well as long as the blockage isn't really close to a blood vessel dividing. Because if it's too close to a blood vessel dividing, it'll kind of push a piece of cholesterol someplace where you don't want it to go. So you can't always use the angioplasty. So they put their balloons in, and they patted their patients on the back, and they said, you did great, we solved that problem. Unfortunately, over the next 3 to 6 months, 50% of those things closed up again. It wasn't really solving the problem. It was a false sense of cure. It really wasn't there. So they had to come up with another idea. So they said, I've got an idea. Let's put in a Chinese finger trap. Have you seen those things? You kind of put them around, they grab. Well, this is a reverse. They put it on the outside of the balloon, they put it inside, and then they blow up the balloon, and they put the rebar in place to hold it open, right? So that was supposed to fix the problem. 3 to 6 months later, half of them are occluded again. It didn't solve the problem. Aha. Better idea. let's make a finger trap and put something on it to keep the cells from growing back. And so we have the medicated stent, right? Unfortunately, it's the same problem, except that the medicated stents, the metal shows, and it keeps contact with the blood, and it increases the risk of a heart attack. So now you have to be on a platelet blocker for at least a year, right? Afterwards, to try to keep that from happening. Oh, this has been so discouraging, isn't it? So, yeah, let's keep moving. We discovered something very interesting about atherosclerosis. And this is, I think they invented this somewhere around 1990. It's called an IVUS, intravascular ultrasound. You know, we were squirting dye into the artery so you could see where the blockage was, and we thought that's where the problem was, where the blockage is. The intravascular ultrasound does it differently. They put it up either the groin or the arm, into the coronary artery, all the way down as far as they can, and at the end of the little wire is an ultrasound. They turn it on, it starts to spin, and then they pull it back slowly, and they get a three-dimensional picture, not just of the lumen, the opening, but of the whole heart. And they actually changed our definition of cholesterol deposits, right? We now have 4 different kind of stages. The first stage is you have some atherosclerosis around part of the artery. The second is that the lumen is open. The second is it goes all the way around and the lumen is open. Am I getting confused on this? I think I've got it. It's still okay. And then the next stage, and this is when we actually see it, it starts to push into the lumen. So that's actually the last stage. The pathologists have been telling us for years, 1940s, there is no such thing as single artery disease. You can't just have one artery blocked. It's all of them. As a matter of fact, it's all of them in our body. So, for example, erectile dysfunction in the male, the penile artery is about the same size as the coronary artery. So when there's erectile dysfunction, that's a red flag that there's heart disease just sitting around the corner. So it's really all the arteries in the body that are getting this all about the same time. Now, it's not always 100% even, but that's the general tendency. Does that make sense to you?
Yeah.
So now we know that it's not just the piece that's blocking the blood flow. It's actually stuff downstream that's weak, that's likely to break open, that causes a heart attack. And that the angioplasties and the the stents, interestingly, do not prolong life. When they're done you need it done if you're having a heart attack right now, okay? That's the time to get it done because that will open it up so it will save heart muscle and you'll do better. But the way we actually take care of heart disease, the best way to actually reverse it is to change the lifestyle. Here's a kind of representation of the angioplasty and of the stents that are put in to try to open it up. Again, they don't prolong life. This has been a great disappointment to cardiologists. It's hard to change that. If there's active angina, if it's unstable angina, get it done, right? But otherwise, it does not prolong life. Here's one of the intravascular ultrasound pictures, and you start to see what's going on really behind the lumen. So there's the lumen, and you can kind of see the cholesterol goes clear around with some this fatty deposit. Look at this longitudinally. And this one is letting us know the lumen is pretty small. The artery is actually stretched out. It stretches out to get bigger, to allow that, keep that lumen so it is open. Fascinating, huh? A little bit discouraging to the cardiologists, and hopefully it will be a stimulus for you. Now, what we've learned is that the cholesterol is not as important. We've learned that the angioplasty and the stent do not fix the problem. What is something that we should be dealing with? We recognize now that heart disease is more caused by inflammation. When you have a heart attack, it's the popping of one of those pimples. It's the increased inflammation in the blood vessels that are actually making them more likely to break open. And so I have listed here, usually I roll them out one at a time, things that cause an increase in inflammation in your blood vessels. This is something worthwhile paying attention to. See, the first one is infections, right? An interesting example of that is dental infections. When you have a dental infection, you're more likely to have a heart attack. There was a pathologist in France who figured out, he's looking under the microscope, and he saw some funny little squiggly things in the arteries of some of the hearts that he was, taking pathology specimens on. Actually, the pathologists get them after they're dead usually, so he was looking at autopsies. And he said, I wonder what those are. And he tested and found out that they were spirochetes from syphilis. Wow. So they took a group of French men, and they randomly assigned them to some doxycycline to kill spirochetes, or none. And those that got the treatment reduced the heart attack by about 50%. So it's amazing. Inflammation makes a significant difference in what happens inside those blood vessels. Now, homocysteine is another one of those things that's important to think about. Homocysteine is an amino acid kind of breakdown product. Comes from the sulfate amino acids that tend to be higher in meat. When homocysteine goes up, it increases inflammation. Other people that can get increased the homocysteine are those that are low in B12, folate, and pyridoxine. So when your homocysteine goes up, there are some people that have genetic enzyme problems that tend to make this go a little bit higher. For example, the homocysteine is worthwhile checking if you're really talking about decreasing the risk of disease. And I'm going to mention it here just because it may help somebody, I don't know. There's a gene called the methylene tetrahydrofolate reductase. And when you get an abnormality in that, it makes the homocysteine go up. It affects 1 out of 5 Americans. And it's kind of, nobody's checking for it. So when I find somebody whose homocysteine is up, I start to look for it and to look for a way to fix that problem. That problem is easily fixed by giving methylfolate and methyl B12. So you bypass the enzyme need, and then you can get around that fairly simply. Autoimmune disease, people with lupus and other autoimmune diseases are at higher risk because it increases inflammation in the blood vessels. Obesity, we talked a little bit about that when we talked about diabetes, and maybe even earlier in the day. When the fat cells in the stomach get full, they start to put out cytokines, which are inflammatory, and they increase inflammation. People who have abdominal obesity tend to have more inflammation. Good news, you don't have to lose all the weight to make the inflammation go away. All you have to do is start losing weight. Once you start losing weight, the physiology changes and the inflammation drops very quickly, especially from those intra-abdominal fat cells. High blood glucose increases inflammation. It does that by driving the Krebs cycle. The endothelium cannot create any insulin resistance. It has to take the glucose. It has to get through. That glucose drives the Krebs cycle, throws out a lot of reactive oxygen species, and increases inflammation. That's when we talked about blood pressure earlier and how it's a blood vessel inflammation. That's exactly what we're talking about. It's that driving of the Krebs cycle to increase inflammation. Diet is important. Insulin secretion, when you eat foods that are high glycemic and the sugar goes in fast, it's doing that thing to the endothelium and increasing the inflammation. And I mentioned, I think last night, about the amino acids that tend to turn our body slightly acid. That also increases inflammation. So a high protein diet tends to increase inflammation as well. A sedentary lifestyle can do that. This is where that computer comes in as a dangerous object to your health, right? So be careful about that. Keep yourself moving. I've got a stand-up desk. My watch keeps reminding me it's time to stand up. I said, I am standing, right? You may have one of those too. And maybe even more importantly here, low emotional intelligence. That is, when you get angry, you throw out a bunch of adrenaline, and that causes inflammation. So there's a list of things that are actually something we can do quite a bit about to decrease the inflammation in our blood vessels. And inflammation is really more important than the cholesterol levels. That's one of the reasons why they've stopped focusing on the cholesterol levels as a reason to start the cholesterol-lowering medications called statins. Now, the reason they still recommend statins, even though they recognize it's not the cholesterol that's the issue, is because statins also lower inflammation. That's why they'll give it to you no matter what your cholesterol level is, because it lowers inflammation. So there's benefit from that standpoint. Wow, I've covered a lot of ground. What time is it? Well, we still have a little bit of time. I think we're okay. Let's take some questions now. I may have shaken some trees, and there's some fruit that needs to fall.
You mentioned the MTHFR.
Yes.
And that can drive up the homocysteine. What did you say is best to combat that?
You see, the problem is taking the B12 and the folate and adding the methyl group. The methyl group is the active group. That's what our body can use to actually make things happen. That's what the homocysteine needs in order to get changed. So, and our genes use it to activate and inactivate. It activates neurotransmitters. I mean, it's really quite amazing. So, when you give the methylfolate and the methyl B12, it bypasses what that gene is short in and allows the body to do what it should normally do.
Why is it that so few clinicians know about MTHFR?
That's an excellent question. And the whole genetic field is a challenging one. I can actually order the MTHFR from my lab. I don't always get it, but I can order it from there. What I often do for people is tell them to do 23andMe. I mean, it'll cost you $100, maybe $150, maybe $200 if you're going to chase your relatives. And then go to a website called Genetic Genie and drop in the data. And it will give you a methylation report, which will tell you whether you have that gene. It'll look at the whole methylation pathway. And sometimes there are other parts of it that are a problem. So that's the way I manage it in the office. And I ask the patient to please get me a copy of that. And then it takes me about 45 minutes to go through all those genes and decide where the problem is. But it's been a very interesting journey trying to make the genetic part of our understanding part of our medical practice. I think it will not happen until the genetic stuff is actually in our EMRs. And it can flop up and say, hey, don't use that medication. That gene really doesn't do well with that one. This would be a better one. So when that's in the EMRs, we'll be able to use it. It's a little bit complicated to get between here and there, but when cases are hard to answer, when people have a high homocysteine, it's now pretty much standard to put them on methylfolate and methyl B12 because that's the likely cause. I mean, it's 1 out of 5 Americans. They don't even do the gene testing. Yes?
If one sibling has the MTHFR gene...
Close.
I tried. Are the other siblings more likely to have it?
Well, this is kind of one of those genes that if you're heterozygous, you have one parent that gave you an abnormality and the other one that gave you a good one, you'll still be able to do it. So that's at least my understanding to a degree. And there's 3 different SNPs, different ways that can be damaged that we know about. Okay. So yes, it's possible that your sibling may or may not, depending on which genes were passed on. You can't tell for sure. Okay?
I have a physician friend who noticed that there was an unusual number of heart attacks in athletes.
Athletes?
Athletes. Yes.
Oh, I'm too far up here.
So in his study, he discovered one of many things, but one thing that was in common was the HDL was exceedingly low in those who suffered the heart attacks.
Wait a minute, HDL? I mean...
HDL.
Oh, HDL. Boy, I am too far up here.
It's my accent.
So the HDL was?
Low.
Low. Okay.
So what's acceptable and why would that create a problem?
I can't give you a good answer on that. I do not know that. There may be a connection, but in my mind, I've never run across it before. I'll put it under the hat and see what I can figure out.
Thank you.
It's coming slowly.
Okay, so I've watched the video many times of Dr. Estelson yelling, "No oil."
Yes.
Okay, so actually in our group, we recommend, sauteing with water or broth, and if you used oil at all, to use it rarely as a condiment, or because when you eat outside of your home that there's going to be oil in the food. So you're saying that eating the whole food is better than using any oil, but is that what you recommend to your patients, not to use oil or sparingly?
So that's an interesting question, and I was asked that by someone privately a little while back, and I'll kind of give you the answer that I gave them. In my book, and especially in the book that is, to help people kind of follow along and make the lifestyle changes, we've floated the concept of a maintenance diet and a therapeutic diet. So someone who has significant heart disease or really bad diabetes, and they're sitting on the edge of something serious, probably better to go on a therapeutic diet. Caldwell Esselstyn, Dean Ornish, these people have demonstrated early that the no-fat diet, no added fat diet, stay away from it, don't touch it, don't even think about it, diet actually works. It may be that you don't have to be there to get that benefit, but we don't know from the science. So we've said, if you're really sick, do a therapeutic diet, get off of it, right? If once you get healthy, once things are improved, then you should be able to go to a maintenance diet. And that doesn't have to be so strict. You shouldn't use a lot of oil. Certainly the bad saturated fats like the palmitic acid from palm oil and others, you'd like to avoid those because those tend to cause trouble. Certainly stay away from that trans fat, right? I mean, those are really bad. And the oxidized cholesterol, I mean, you be healthy, keep your fats low, but you don't have to be, what's the right word, religious about it, okay, if you're on the maintenance diet. Does that help? Okay, that's the way I look at it. I've been part of arguments with Caldwell Esselstyn about that. And he backed down. He said, we really don't know for sure. It's just what I did. And if I tell my patients they can have a little, they'll cheat. So he says, no, I just absolutely no oil. And so that's a reasonable thing to do for behavioral reasons and from the science reason. But we don't know that it's absolutely necessary. Okay, thank you.
Please comment on the causes of inflammation and their relationship to arrhythmias, heart block, bradycardia, atrial fibrillation, tachycardia.
As far as these fats are concerned?
Yes.
Fascinating article that I found a couple of years ago on epicardial fat. So the epicardium, that's the top of the heart, has within it pluripotential cells that will actually go into the heart after the heart muscle has died and will replace it. They'll rebuild it. It takes time. I mean, it's not something that happens quickly. It ends up that as the epicardial fat builds up, the fat on the heart, you increase the inflammation, and you significantly, according to the article, increase your risk of atrial fibrillation. So there is a kind of a dietary connection that may be because of the cytokines that are being released from that epicardial fat. They really couldn't tell me they could postulate, but they didn't know 100% for sure. But there is a connection there. As far as things like PVCs and ventricular fibrillation and those types of things, I focus in my practice more on both the external and internal cardiac stimulants, right? So external would be things like, nobody does cocaine here, but it happens. And caffeine, which is a real cardiac stimulant. You have a cup of coffee in the morning, when you go to bed that night, 1/4 of that caffeine is still in your blood. I mean, you have that kind of constant stimulation. And adrenaline, of course, when you kind of get upset, will get the heart as well. We know that beta blockers tend to help calm that down because it blocks that effect. That's a type of medication for those of you that aren't medically inclined. And then I often put them on magnesium. I've been doing this for quite some time because of some lectures I heard at the American College of Nutrition on the benefits of magnesium. But I've been pleased to know that some of my cardiac specialists in my neighborhood are actually recommending that patients start taking magnesium. Magnesium works like a calcium channel blocker. That's for those of you who are medical. And it calms muscles and nerves down. It just kind of lowers their excitability. You may know that, well, it was mentioned somewhere, that it's used sometimes when there is preeclampsia and the uterus may be going into contractions. So we use the magnesium to kind of calm things down. There are some who are using IV magnesium in the emergency room for migraine headaches. It calms the kind of things down and relaxes them. And so it helps to calm the heart down as well. So I usually start with my patients with PVCs or PACs. Instead of sending them to the cardiologist, I can do the Holter monitor, put them on magnesium, and often it just calms down, and they really don't need the cardiologist. Okay, so that's kind of a family doc. You know, we get our fingers into everything.
Hang on. Allergies, I'm very allergic to ragweed. Is that considered an infection, or is that, I don't know, that homocysteine?
Homocysteine is not part of an allergy. So I'm sorry that you're allergic to ragweed.
That's not on that list, is it?
Yeah.
No, not an infection.
Cardiovascular recommendations, guidelines, the American College of Physicians, the American College of Cardiology, the American Heart Association, the American Society for Thoracic Surgeons, and Preventive CV Nurses Association all got together, the Annals of Internal Medicine in 2012, and stated lifestyle change in medical therapy should be mainstay for most patients with stable coronary artery diseases. You know, going after with a stent is really not the answer. It does not prolong life. There have even been studies that say it. They did some study where they did either an angioplasty or a sham operation. That is, they put the catheter up in there, but they didn't do the dilation. And there was no difference in the symptoms after the procedure, and those that had the placebo or not. So there's a lot of argument going on about that. It takes doctors a while to kind of change their minds and kind of prove things. It took 10 years for surgeons to stop doing total mastectomies for breast cancer when it was proven that lumpectomy was just as good. You know, we doctors are MD-headed, and sometimes it's hard for us to change our practices. Okay, we got another question.
You go ahead. No, wait.
Oh, I'm sorry. Do you recommend magnesium for everybody to take daily?
I have been accused of that. My residents say he wants magnesium for everything, okay? I have read enough and heard enough that I know that we don't get enough. The NHANES data says 50% of Americans are not getting the recommended amount on a daily basis. And if you look at people over 65, it's 80% are not getting. So I personally decided to start taking magnesium myself just because I think the benefits are there. And so it's part of my longevity plan. Do I have good science for that one? No, but that's what I'm doing. Okay. He says, do you recommend a dosage? Okay, well, we talked to the ladies about that last night. As much as your bowel will handle. You ever heard of milk of magnesia? Okay. Now that works fine unless you have kidney failure. Severe kidney failure, you can't get rid of the magnesium. That's a whole different ballpark. Magnesium only really with blood levels to check and make sure it's okay. But for most of us, magnesium can be decided by our bowel function. And when my mother-in-law came to live with us at about, 94, 95, she died last year at 104, okay? Wow. So when she moved in with us, I said, Mother, old people complain about their bowels a lot. Here's some magnesium. If they're too hard, take more. If it's too soft, take less. So she had a way out, and I think it worked okay. That's probably a good recommendation for you as well. Okay. I think we've about used up our time. There's another question over here. I think we've covered things fairly well and hopefully answering questions. I'm happy to stay by afterwards, by the way, so, yes.
Okay, if you could just clarify, I think a lot of people have the idea of plaque in the arteries being similar to calcium deposition in our house pipes, and that somehow you can chelate and get rid of these depositions.
Okay, so they want you to take chelation agents. You go and you get the IV of chelation. Yeah.
How can can you actually reverse that type of deposition in the arteries?
The good news is that kind of deposition is reversible. The good news is that chelation doesn't work, okay? So now I say that kind of categorically and maybe even tongue-in-cheek. Maybe there is some literature, but what's going to get chelated of calcium when you put it in the IV? It's the calcium in the blood. It's not going to go into the artery and pull it out. So when it pulls it out of the blood, that calcium has to come from somewhere. The body has to keep the calcium level perfect. If it's not perfect, you start to have really bad symptoms. Try it sometime. Hyperventilate, right? And your fingers go into spasm and you get tingling around your mouth. That's the calcium level going low because it's being bound to the albumin by the pH change from hyperventilating. So the calcium in the blood has to stay steady. So it has to be replaced from somewhere, and where that's done is from the bone. So it really doesn't make sense to try to chelate it out. Now, it is reversible, and I was pleased, it's probably been 10 years ago, I found a scientific article that actually gave the biochemical steps for how the atherosclerosis is pulled out of the artery. Science understands, is able to explain how that stuff is removed. And you do that by going a low-fat diet, keeping the insulin and the sugar down, the inflammation down, and your body starts to reverse that. God has built an incredible amount of grace into our body. When we start to obey his laws, we get the benefits. Okay? One more. Okay.
You were talking about caffeine and how it's a heart stimulant. Well, in 2005, I had open heart surgery. I had 4 clogged arteries. And since then, I haven't had any trouble. But the part that worries me is the fact that I love coffee. Now, I haven't had any problems. There wasn't any damage to my heart. But are you recommending that somebody that's actually had open heart surgery should stop drinking caffeine? Or
caffeine is a cardiac stimulant, so it'll make the heart more irritable. I don't know that it has a big effect on the atherosclerosis, but it makes the heart more irritable.
Mm-hmm. Okay, and also inflammation, you were talking about that. Does that include, you said autoimmune diseases, but like arthritis is also a type of inflammation.
There are some arthritises that are autoimmune. Rheumatoid arthritis is, okay? Osteoarthritis is not.
Oh, good.
So it's not all arthritis.
Not that kind of inflammation then.
Well, it's interesting. When people go on a plant-based diet, their joint pain tends to go away too.
It does?
Yes. It's one of the first things I hear fairly frequently.
Okay,
Yeah,
well, thank you. I'm sorry to bother you.
No, you did fine. Well, we've had a good time. We've interacted. You have pushed my buttons, and I have responded as best I could. You discovered that when I don't know the answer, I try to say so. When it's opinion, I try to say so. And when there's science, I try to say so. So that tries to keep it honest and above board. It's been great fun. I'll be here for a while afterwards, and I'd be happy to talk with those of you that would like to. Is it okay if we close with a word of prayer?
Yes, please.
Father in heaven, we're thankful for your creation. We are fearfully and wonderfully made. We are again thankful for the grace that you have built in and that you are teaching us to live by your laws. We pray for your Spirit to not only help us understand, but help us do that which will bring us the best health.
Yes.
Thank you for your healing. In Jesus' name, amen.
Thank you. Stay put. Stay this way. So, thank you so much. Just a reminder, we do have these books available for a donation. But you were telling me, Dr. Guthrie, that there's a journal that accompanies
That's
this.
right.
Would you share about that?
Wow, that was very kind of you to
I've
set
got
that
you
up.
going. Eat Plants, Feel
So
Whole.
Eat Plants, Feel Whole journal is available. It's a much thinner book. The first half of it is kind of some philosophy about the therapeutic and the maintenance type diet. And then we set the book up with the 18-day program so people who want to actually do things at home can have something therapeutic that they can do. To help others who like to really log things, we made this journal. And you know, a lot of people think about dietary changes, about what you can't eat and what you can't do. I mean, it seems to be more in the negative. So the journal is a positive, and there are 2 18-day cycles within the journal, so you can do it with a friend or a spouse, or you can do one after the other if you need it. And each day is positive. So, there's the required, so you have to get 3 servings of berries, or 2, whatever it is. And then you get extra points for taking more, right? So you try to build up points. And it does much more than just foods. It also deals with the rest of our lives. There's, for example, a place for mark down exercise that you've done. There's a place to put down gratitude, things you're thankful for, and you get kind of points for each one of these things. We even put in one for random acts of kindness, right? So do something, and as you do that, your whole lifestyle is improving. So those of you that like tracking what you're doing, science tells us tracking what you're doing works, so we kind of put the journal together to help people do that. You don't have any here, and that's fine. You can get them on Amazon or from AdventHealth Publishing. So
Yeah, well done. Thank you. Thanks for joining. Yes.
there's a cookbook coming out in the next couple of months.
We love
That has
cookbooks here.
some incredible recipes in it.
Thank you.
Okay.
We love cookbooks. Well, thank you for staying around for questions. Come on up. He likes to talk, you can tell. We're good. Thank you all very much.